Thanks for coming, everyone. It really is cool to be able to do this. I'm going to talk about preventing homeless deaths, and I need to start by talking about homelessness, and we'll work our way through homeless deaths and then some of the practical things that we've tried doing to work on reducing mortality. People always say, I don't have any disclosures. I think there are, it is important to say, I work in the San Francisco Department of Public Health, and public health shapes my thinking and how I work and approach the world. I don't know how many lectures start with a quote from Maya Angelou in this day and age, probably most of them, but I like this one. The ache for home lives in all of us, the safe place where we can go as we are and not be questioned. And I say that because when we talk about homelessness, we're not strictly talking about someone who has no house or someone who has no shelter. We're talking about something that is a really profound thing to lose. So generally, I am not dogmatic in my speech or in my ideas. So this is about as close to dogma as you're going to hear me get. Homelessness is a result of poverty. Poverty is a result of disadvantage, discrimination, and disability. Homelessness is a result of lack of affordable housing. Lack of affordable housing is a result of policy, primarily at the federal level, that results in a drastic situation where we don't subsidize housing for people in poverty, and therefore there is no housing for people who are living in poverty. When we use the word homeless, certain things come to mind for me. And we're talking not only about poverty, but we're also talking about survival. We're talking about shame and stigma. We're talking about suffering. And these are all things that are interacting at the personal level for somebody experiencing homelessness often. Just a quick visit into the politics of this. This is actually a graph. This is a graphic from WRAP, the Western Regional Advocacy Project. I'd definitely recommend people look at their website, WRAP. But this is funding for subsidized housing for poor people in this red line here. And you can see at its height, late in the 70s, we still didn't have enough, but there was quite a lot. And then you can see the drop in funding and the rise in numbers for homeless people. And that basically just graphs itself out, almost a perfect fall in federal funding, rise in mass homelessness. How many homeless people are there? I sometimes do this as a quiz. I'll spare you all that. And say, in a single night count, more than 500,000 in the United States. More than 100,000 of those are represented in California, and about 7,500 in San Francisco. That's a single night count. The Department of Public Health, in various systems, registers individuals according to their status related to housing, and we register 14,000 to 15,000 people as homeless for health care services a year. So that's a discrepancy right now, and it shouldn't be surprising if you go out, even with enthusiastic volunteers, to try and count homeless people on the street or in homeless shelters on a single night. You're going to miss a lot of people, and a lot of people aren't necessarily homeless on that particular night, but they will be homeless for significant parts of the year. Another way of looking at and thinking about people experiencing homelessness, there were over 120,000 homeless children in the single night count across the United States. And yet, almost 2.5 million children were counted as homeless by the United States Department of Education over the course of 2013. A huge difference. and speaks to the hidden populations of homelessness among families. 15, 20 years ago, we tried to estimate really the number of people in the country who were homeless, and there were consistent numbers around 2.3 to 3.5 million people experiencing homelessness in a year before they stopped trying to count or estimate that. And I think, again, that speaks to some politics. We've put all of our efforts into the single night count without really looking at what's probably most significant, which is looking at it across a year. It shouldn't be surprising to say that there are inequalities in who it is that is homeless, and that in terms of homelessness, African Americans are far overrepresented for their numbers, both nationally and in San Francisco. And then other minorities are also overrepresented, and that's comparing a homeless population to the general population. Again, trying to look at what is the makeup and what kind of factors are important when we think about why are people homeless and how do we help people who are experiencing homelessness. A couple more slides on this. This slide is showing in the dark blue the general U.S. population, and in the, what is that, aqua green or something? People experiencing homelessness. This is, again, around 5% prevalence of mental health disorders in the general population, around 25 to 30% in the population of people experiencing homelessness. Substance use disorders, again, around 5%. General population, 20% or more in the homeless population. Cognitive impairment, again, this encompasses all cognitive impairments, various kinds of dementia, various kinds of consequences of a head injury, other things. And that's kind of higher than other things. But a lot of studies actually have seen 50% or more cognitive impairment in people experiencing homelessness. Again, that becomes very important when we talk about what kind of things do we need to do when we're taking care of people who may have some kind of problems with memory, thinking, judgment. I want to really spend a moment looking at disability, because it is true that in the United States we have rather large numbers of people who are figured to have a disability. But the numbers in terms of homeless population, almost 60% of our homeless population with, this is significant disability, should make us think again about those pathways to homelessness and how do people get into such severe poverty that they can't afford a place to live. And much of that is related to health-related disabilities. And ultimately, that boils down into excess of homeless deaths. And nationally, there's a homeless death memorial every year at the winter solstice. Here in San Francisco, that usually takes place in Civic Center Plaza on the day of the solstice. But wherever you're coming from, often there's local ceremonies to memorialize people experiencing homelessness who died. So homeless mortality in San Francisco. What do we know? And what did we do? I looked at information from the medical examiner's office and looked at clinical information we had. I'm going to describe that in some detail, and I promise you, I'm getting to opioids and overdoses and drugs and death here soon, but I think telling the story helps a little bit. The work that we did on homeless mortality, it tells us the number of people experiencing homelessness who died in San Francisco 2016 to 2018, based on an extensive case review of medical examiner reports. It tells us who these people were and what interactions they had with health and social services prior to their death. And it tells us the most common causes and locations of death among those people experiencing homelessness. What it doesn't tell us is how many of those deaths are attributable to homelessness itself. And it doesn't tell us the rate of deaths among people experiencing homelessness relative to the general population of San Francisco. And it doesn't tell me about the number of homeless deaths in San Francisco that were not medical examiner cases. So just keeping that in mind. Why did we do it? To lead us to understand how to improve our clinical practice and how to plan in the Department of Public Health for prevention efforts. It helps me in real time, because I have these cases reported to me on a weekly basis, to go out to those locations where someone died and see who else is out there and how somebody dying how that death may have affected other people in that area. And it also lets us really work on city priorities between agencies where we may start out with different ideas about what is the most critical thing in homelessness. After all, homelessness is the #1 political issue in San Francisco. Every mayor's race in San Francisco since I've lived here in 1991 has been run and won on a platform of, if you elect me mayor, I will fix the homeless problem. Now, I don't think I'll get deeper into those politics, but just saying we need data and information to help figure out, well, what does that mean, and fixing what, and how do we prioritize? So what did we find? We had looked at this information in the 1990s, and it looks like between 2016 and 2018, both the numbers were steady, and I'll share those with you in a minute, and not so different than what we found in the 1990s. We find that there was a high prevalence of alcohol use among the people who died, and that overlaps with those people who frequently go to the hospital, who are in the emergency room frequently, and who are admitted to the hospital frequently, and other emergency services. We found a high prevalence of methamphetamine use and an overlap with the criminal justice involved population, and an overlap with high users of medical and psychiatric emergency services. We found a high prevalence of opioid overdose, but possibly less than would be expected considering the national trends over the same period. As I think anybody who hasn't been sleeping over the last 5 to 10 years would have heard, we've got an opioid epidemic in terms of overdoses across the country. And in a lot of places, and in a lot of places when we've looked at homeless populations as well, those numbers of overdoses have increased 5 to 10 times over the past 10 years. San Francisco, they've remained pretty steady over that period of time, still way too high. High prevalence of violence and other trauma. Again, this is something I know clinically taking care of patients. Every day I see patients who talk about being assaulted, being a victim of some kind of violent event. And again, often in the rhetoric of homelessness, we hear about people experiencing homelessness as being violent and scary. And it's very interesting to realize just how much of that victimization is actually occurring to homeless people themselves. And last of all, but possibly not least, there may be a role of shelter when we compare our homeless deaths to New York, for example, where more people are sheltered. They have 10 times more homeless people, but only about twice the number of homeless deaths using similar kind of methodology. We don't know why that is, but one difference that we know between San Francisco and New York is that there is a mandatory sheltering in New York, and there's a shelter bed for every homeless person who wants one. Our response is to continue and enhance the SFDPH response to the opioid overdose epidemic, and I'm going to have a lot more to say about that in a minute. The Department of Public Health and other city departments have established a methamphetamine task force. and other clinical and population health responses to the methamphetamine use. We are in the process, the beginning of the process, I must say, of evaluating and improving our system of care for individuals who are homeless with severe alcohol use disorder. And we are looking at incorporating homelessness as a risk that may need specific prevention strategies around violence and injury prevention. I'll point out one area. I'm sure many people have seen the efforts in San Francisco to reduce the number of pedestrian deaths. Vision Zero. It's a great project from the Department of Public Health, but it became clear as we looked at numbers, actually a substantial number of the people who were killed as a pedestrian in San Francisco were actually people experiencing homelessness, and we need special approaches to try and really address that. And intensive efforts to reduce the number of unsheltered people experiencing homeless. You may have read in the paper the number of homeless people who die a year in San Francisco and seen numbers like 40 or 50. And you'll see our numbers are higher than that. The reason was we really weren't looking at all of the people who are homeless. The medical examiner's office doesn't have a category for homeless. They've got a category of no fixed address if they really can't track down a living address of somebody who died. But looking at our clinical records, we were able to include a whole lot more people who actually were experiencing homelessness. And that gives us a chance to have a more complete picture. So what did we do? We worked with the medical examiner. Medical examiner cases, I don't know, I find this fascinating. You become a medical examiner case if you die in San Francisco of an accident or injury, or if it's thought that there was a possible homicide or suicide, if you die alone, solitary, if you are somebody who dies and a doctor is unsure of the cause of death, if you are a victim of poisoning of any kind, if you are a victim of a death of any kind that's related to any kind of criminal activity, even if homicide is not suspected, if you die and you're not identified, and if you die and you're so poor that there's nobody to pay for the funeral expenses, you also get reported as a medical examiner case, although they don't do a full investigation. And they send me all their cases that they think might possibly be of interest to me. So anybody with that no fixed address, indigent, all the indigent cases, and anything else where they might think somebody was homeless or living in an SRO based on the circumstances of their death. Then we take all those names and we put it through something called the Coordinated Care Management System, which is a big database, several million people registered in that database that kind of vacuums up all kinds of information from the Department of Public Health medical records and a bunch of different electronic systems that looks at people's health status, what kind of medical conditions they had, what kind of living situation they had, and how much they use care. So we kind of put those two things together to be able to generate a report. Maybe I should have started with this, but I really wanted to build up the suspense here. 2016, 128 homeless deaths. 2017, 128, that's not a typo, that somehow was exactly the same. And 2018, 134. 53% were considered in the medical examiner category of accidents. Unintentional overdose, falls, drowning, pedestrian versus vehicle, inhalation, exposure, all those are in that area. 11%, and that's a higher number than I would have thought, of the homeless deaths were attributed to homicide. And that included firearms or sharp injury or blunt injury and officer-involved shootings. 30% were considered natural. Probably if you look at all of the homeless deaths, more than 30% are dying of natural causes, but many people who die of natural causes die in a hospital and they're not going to be a medical examiner case. We're going to look at those next year. Only 4% were suicide, and the medical examiner was very surprised by this because in the city as a whole, suicide deaths are actually higher than homicide deaths. So it's something that we puzzle about. Why are there less suicide deaths in this group? And only 2% are undetermined by the medical examiner. And that they're very, very aggressive and conscientious about really tracking a manner of death. Circumstances of death, contributing factors. These are factors that were listed as a cause of death or contributing condition or were in the toxicology report from the medical examiner. And over half, drugs was involved or contributing. A third, alcohol was involved or contributing. Another third, natural history of chronic diseases. And again, over a quarter, violence or traumatic injury. Another way of looking at this was just looking at the toxicology reports that we had. And again, toxicology is looking for drugs in body fluids. Somebody dies, whatever drugs were in their body at that moment. Usually that means drugs that people had used somewhere between the last 12 hours to 2 or 3 days, depending on the substance. Almost half the whole group had methamphetamine noted in their urine. And that's really important for understanding what's going on in San Francisco now, because that was not the case 20 years ago, and it's not the case in cities across the country. Still close to half opioids, and that's some people who died of an opioid overdose, but that's also a whole lot of people who had some other cause of death. A third cocaine, a third alcohol, and about a quarter has some kind of sedative. And lots of people had lots of different things. Now, interestingly, the way this data works, there's a backlog at the medical examiner. So mostly I have the toxicology results from 2017 and before. And only 4% of our cases included fentanyl. And now we know we've got a increasing problem with fentanyl in San Francisco, and I'll talk more about that in a minute. I'm sure that would be higher if we look at it today. Some demographics, 82% of the people were male, 17% were female, less than 1% were listed as trans. Again, the medical examiner doesn't really have a way of knowing who is transgender, and they're going by anatomy. The average age was 51. I'm really interested in this age spread because we talk a lot about the aging of the homeless population. And indeed, we see a full range from 20 to greater than 70. And pretty big group are the 50 and over people. And in one way that seems like, well, of course people who are dying are the older people. And on the other hand, that's a homeless population that often has been homeless for a very long period of time. Most common cause of deaths based on autopsy, I'll just highlight the number one acute drug toxicity, unintended overdose. It's our number one cause. And then a range of other things similar to what I was talking about before. Contributing factors, again, drugs and alcohol really being important. Drugs plus alcohol, drugs plus violence and injury, alcohol plus violence and injury, alcohol plus chronic disease. Again, it's starting to give me a picture of where do we need to put our energy. This breaks the toxicology results down by race. More white people using methamphetamine than African American people, but 10 years ago, you would have been hard-pressed to find an African American person using methamphetamine in San Francisco. It had a real change in the pattern of drug use. That's important. Again, opioids, pretty high numbers for both white and African American population. It's how long people have been homeless. We're able to track that in our systems, and most of the people have been homeless more than 5 years, and in fact, over 40% of the people homeless more than 10 years. So length of homelessness matters in this. Most people did not stay in a shelter. 68% of people did not stay a single night in a homeless shelter during the period 12 months before they died. Many people had some contact with our healthcare system, but a lot of people were not in that high user category that we worry about, people who are going to the emergency room or being admitted to a hospital all the time. A lot of these folks are people who are just staying under the radar, and then something happens. These deaths are really spread out through the city, but concentrated downtown, Tenderloin, south of Market, Mission District, and if we look at Tenderloin, south of Market, Mission District, we can see kind of spread through there. So now that I've kind of done the downer thing and said where we stand, what are we doing about it, and what can we do about it? And we've tried to come up with some innovative programs that recognize what's going on and how do we reach people who we weren't reaching before. So I'm very proud to talk about our low-barrier buprenorphine program, or our low-barrier medications for addiction treatment program. And I want to thank our addiction fellow from last year, Jamie Carter, who did a lot of the work on allowing me to actually have data to be able to show you here. So the background. 2016, I think I will, I'll introduce our Director of Prevention and DPH, Tomas Aragon, who's here also. Tomas will remember that in the fall of 2016, the Director of the Department of Public Health called a big group of Department of Public Health leadership together for a meeting. The meeting was, the mayor says he doesn't like seeing shooting up drugs in Civic Center Plaza directly across from City Hall. What are we going to do about it? The mayor says it's a public health problem. And I think we all in the room agreed it was a public health problem. But what are we going to do about it? So we identified certain things. Why was this problem? Public complaints, needle waste, overdose deaths, disease transmission risks. People shooting up in public, that is really a big public health problem. Who are these people? Usually homeless. If you have someplace to be, you're usually not going to be out in public doing what you would ordinarily want to do in private. Usually people who are using heroin, people who have severe opioid use disorder. And we know that, again, we have pretty good treatments available in San Francisco, but these were folks who were experiencing barriers to treatment with methadone, barriers to treatment with buprenorphine. These are medications, and I'll go through them a little bit in a moment, that are very effective for treating opioid use disorder. So we asked ourselves, why aren't these people taking advantage of those treatments? When we talked to people, it was not because they were so content with their addiction and shooting up on the street. We found huge amounts of distress, shame, and desire for change, but we also found huge amounts of barriers. So why are we talking about this? Partly we're talking about this because things have changed with the introduction of fentanyl and other potent synthetic opioids in the country and now in San Francisco. And these are drugs that are much less predictable and much more likely to result in an overdose death. What's the general response and our harm reduction response? Keep calm and carry naloxone. Naloxone's the antidote for an opioid overdose. In San Francisco, we've been distributing naloxone to drug users and people who are likely to be around drug users for quite a number of years, very aggressively. It's been a very important harm reduction activity that actually we believe has been one of the reasons we haven't seen that skyrocketing escalation of opioid overdose deaths that a lot of places in the rest of the country have. We also looked at, is there some place that we can take people who weren't overdosed so severely that they needed to be revived, but seemed to be at risk, and can we bring them to our sobering center, which usually is used for sobering up people with alcohol use disorder, and we piloted that. We tried to really do a lot of education and outreach related to reducing syringe waste. Again, people do not think it's a good idea to shoot up and leave their needles on the street. There's lots of reasons why people might do that, and we really looked at how are we going to reach people and really say, you know, we know you're struggling, but this is a major problem. Practical things. Here's how you get rid of them. We're going to come around daily and be available for you to dispose of your waste. So a lot of work with a lot of public health partners on that. And then we recognize a need for low barrier access to buprenorphine treatment. And we started with targeted outreach and a patient-centered approach adapted to the needs of the homeless population. So what am I talking about? Opioid use disorder is a medical condition. It's characterized by loss of control and compulsive use of opioids despite harm. First-line opioid agonist treatment, methadone or buprenorphine. These are evidence-based treatments for opioid use disorder that help to keep people in care, decrease mortality, reduce the amount of opioids people are using, reduce people's risk of infectious disease transmission, and improves other health and social outcomes. They work if you can only get them to people. Methadone is highly regulated, dispensed daily through opioid treatment programs. If you want to get methadone, you have to go every day to a specific place. Buprenorphine can be prescribed in an office-based setting by doctors, nurse practitioners, physician's assistants who have had special training and obtain a waiver from the federal government. Historically, buprenorphine was used for more stable patients. And often it was started with what's been called an induction in a doctor's office. But we've learned a lot in the 15 years that buprenorphine has been available. There's lots of ways to learn about methadone and buprenorphine, but I think the adventures of Methadone Man and Buprenorphine Babe is surely one of the best ways for our patients to learn about this. Buprenorphine comes in a bunch of different forms: sublingual tablets that people dissolve under their tongue, sublingual film strips that people dissolve under their tongue, film strips that stick on somebody's cheek, implants that can go in somebody's arm and last for 6 months, and now, relatively recently, an injection that goes subcutaneously like an insulin shot and lasts up to a month. So lots of variations on this. And in our state, our Medi-Cal program for poor people who don't have other insurance actually pays for all of these forms of buprenorphine. So if somebody's got Medi-Cal, we're able to obtain it for them. A lot of people have the misconception that these medications are just a substitute or exchanging one addiction for another. And I hear that from my patients. I hear that from my family members. Perhaps I'd hear that from you. There's evidence that these are really beneficial, but that doesn't really answer the question, well, isn't it just exchanging one addiction for another? So really more evidence, A, if you're using buprenorphine or methadone, that's quite different than what we mean by an addiction. And B, actually, buprenorphine, and perhaps methadone to a little less extent, but methadone too, shows amazing improvements in the physiology compared to somebody who's using a short-acting opioid like heroin or fentanyl or short-acting opioid pharmaceuticals compared to the very long-acting opioids of methadone and buprenorphine. You can just watch all of the stress hormones that are way up here normalize. You can watch the endocrine system, the immune system stabilize over the course of time when people stop using short-acting opioids in a chaotic way, start using these medications in a regular way. For our patients, we often also can say confidently that sexual function improves, and sometimes that's a motivation for some of our folks. This is naloxone, the antidote for an opioid overdose. I carry one on me at all times. You see the slide, but so I'm not going to pull it out of my bag. But I'd say anybody who is around places in San Francisco where drug users might be, there's just about nothing worse than the feeling of walking by someone and they might seem to be passed out or even breathing slowly or stop breathing, and you're going to do all the things that we know to do. You're going to call 911. You're going to start CPR. And for many people, if we've got naloxone, which is available as a nose spray or an injection, or even a talking injector that tells you exactly what to do, hey, if I'm carrying that in my bag and can pull that out and maybe save a life, that feels a lot better than standing by. That's what I tell almost all of my patients. Not only do I encourage that my patients who are using drugs carry this, because they're usually using drugs with other people who might have an overdose, but even other patients who might be a bystander. They're around a concentration of people. This is a way to, A, save a life, and B, it is amazing when people come back and say, I saved somebody's life, how that person who might be homeless, hopeless, really lost meaning in their life, how that can really change somebody's point of view. I saved somebody's life. So I'm a big fan of naloxone. We went out and we surveyed our patients and made a long list of what the barriers to opioid use treatment were. I'm not going to go through all of these, but not having insurance or Medi-Cal, not having an ID, and not being able to leave the area where you are because coming to a doctor's office might mean that all of your stuff gets stolen or lost, were important things. And we just went down this list and started to check off what would we need to do to reduce that barrier. No insurance. Somebody is not going to go to the Medi-Cal office, sit for half a day, fill out 30 forms, and be able to get through that whole process and then come back tomorrow and do it again until they actually get signed up for Medi-Cal when they're strung out on drugs. And it's just not going to happen. It's a lot better chance it's going to happen if we start to treat that addiction and then ask people to get their Medi-Cal. So get people this medication, whether they're insured or not. That's something we worked with the Department of Public Health to assure that would happen. Again, each of these things we start to check off how we would reduce that barrier. I'll go through some of the things that we ended up doing. So target population, homeless, injecting drugs in public, severe opioid use disorder, it's almost everyone, high risk, high vulnerability, not able to benefit from care otherwise available in San Francisco. We said, hey, if you can go somewhere else, we want you to go somewhere else. But if you can't, we're going to take care of you. We're going to redeploy our resources. We added an outreach worker, and we started to do outreach, engagement, trust building with people on the street, assess people wherever they were. Somebody wants to walk into our open access clinic, great. Somebody is going to a site where they can get access to clean syringes, great, we'll be there. That's a likely place that a lot of people who fit in that target population are going to be. Streets, parks, shelters, navigation centers, all of these are areas we know with a concentration of the target population. Let's go there to them and let's start this vital medication in that place. We're already working in San Francisco on other projects of how do we start this in the emergency room. Our course director is really providing leadership in that. Doctors' offices, if people can make them in. So really trying to push beyond those barriers. Our model is we assess people, we provide a transitional primary care. We're not just doing drug treatment, we're trying to really look at people's overall health and do whatever we can to help their health. Often that's prescribing these medications. We're working with trained peer outreach workers. As I said, we're working in some of the sites. We have an open access clinic at 50 Ivy Street, 6th Street Harm Reduction Center, navigation centers, number of other sites. We do an assessment. We prescribe the buprenorphine. We educate and prepare people for how do you start it. It's not that complicated. We make a care plan. How long are you going to be taking this? When are you going to see us next? We make a plan, we make a backup plan, and we make a backup to the backup plan. That's how you do good homeless health care. That's the gospel according to Barry Zevin. Then we say, look, I can't predict who's going to do great and who's not, but we start people. In the first year, and I'm going to show you some little statistics and result, in the first year of the pilot, we did 100 patients. We're now into the middle of we're at year 2.5. And we're possibly today, we may have crossed the 500 patient mark of people who we saw and started buprenorphine on. And many of those people are still in care. And I'll show you some of how we look at, is this working? We want to keep people in care, and we want to improve people's health. We'd like people to reduce their opioid use. We'd like people to stop completely, but we recognize we might not get there on the first day. We might not get there in the first year. It's really hard for people experiencing homelessness to make drastic life changes. Sometimes people do. In some ways, that's more surprising than people who make the slow changes. We usually start people, we generally see people 2 to 4 days after their initial visit. While people are being treated with us, we often see people weekly, sometimes if they're stabilizing every other week. People have access to our open access clinic 4 days per week. We're often doing outreach. We're really trying to reach people, and it's pretty intense. I don't know, it's hard to do in a regular doctor's office if you say, you need to see people once a week for maybe 3 to 6 months before they start to stabilize. It's like, wow, that's a lot of medical care. But we've got a model that uses doctors, nurse practitioners, nurses, health workers, peers, to be able to really get our eyeballs on those people a lot and provide the support. And when people do well and then start to do bad again, scaffold what it needs to be scaffolded so they can be doing better. We're doing outreach to people who don't come in the way that we expected them to come in. We've got expert counseling available through the Center for Harm Reduction Therapy. Again, generally drug counseling is at a peer level, perhaps at a level of somebody who's certified after a 3-month program or a 6-month or a 1-year program. Our counseling really uses people at a master's degree level who are trained both in mental health and in addiction treatment. And I think that's very important in this population because so many of our folks are suffering from the results of severe repeated traumas, often since childhood. We check urine toxicology. We check to make sure people are taking their medicine. We check to talk to people about what other drugs they're using, and we're tracking that. If people don't stabilize, we're able to do observed dosing at our pharmacy. We're able to refer them to opioid treatment programs where they might have methadone or buprenorphine available. Or we're able to refer them to residential detox or residential treatment programs. So we've got some access to other care. We did the pilot. What did we find out? So 1-year period, 95 patients were evaluated and received at least 1 prescription for buprenorphine. 75% were male, 25% were female. Now, that's concerning. We don't think there are only 25% of our homeless opioid users in San Francisco are women. On the other hand, we know from our information about homeless deaths, it's predominantly men who are at risk of dying. So I don't feel so bad about this. I think we're reaching the right population, but we've also are learning from it. One of the things that we learned is it's actually pretty hard to target your services just to women. Women in this population are almost always attached to a man in some way. Okay, how about we do couples? Now, this is like fools rush in where angels fear to tread. This is not a standard kind of way of thinking about addiction treatment. But said, look, if the women won't come in, we're going to see the women as part of this couple. Even if that relationship does not seem healthy, possibly even abusive, if they will come in with a partner, or the partner will come in with them, let's see them together. Let's work at it together. And that's an innovation that I really hope next year we're going to be able to report on some real successes with that and increase this number of women who we're seeing. Population-wise, mostly white. In the first year, about 18% African American. Again, we know that makes up a larger part of the population at risk, and we know historically that's been underserved population, and I think we're really trying to, in the first year, we did nothing to outreach areas with a predominantly African American population. Now we're working more in the Bayview Hunters Point neighborhoods where, no surprise, there's a lot of homeless people who are using opioids. 58% have a chronic medical condition. That's a lot. That's people who are not healthy drug users. That's people who are having serious medical conditions. 2/3 have a diagnosed psychiatric condition. And by self-report, 25% had bipolar disorder or a psychotic disorder. Again, we're trying to really work on that model. We added a psychiatrist and a psych NP after the first year. As I said, Department of Public Health has a world-class model for how to start buprenorphine before we started. You can make an appointment at a place that's called OBIC and go and get started on buprenorphine there. We found there were a number of barriers to that and predicted there would be a number of barriers to that. And amazingly, in this population that's been out there a long time, only a quarter had ever even tried to use this clinic because they don't take people who don't have insurance. It requires an appointment. The gospel according to Dr. Zevin again. Appointments are the enemy of people experiencing homelessness. Anything that we target for people experiencing homelessness, if we do it based on being at a particular place at a particular time on a particular day, that's going to be pretty hard because just in the nature of homelessness, it's hard to get to appointments. 61% not only used opioids, but also used methamphetamine. Lower numbers for the other classes of drugs. But again, there's no place in the country outside of a few West Coast cities, San Francisco, Portland, Seattle, Denver, San Diego, strangely not LA, not Vancouver, where you'll see large proportions of your opioid users also using methamphetamine. You've got to know the local conditions, and that creates a challenge because methamphetamine has a whole nother layer of challenge to it in terms of treatment than just opioid use disorder. How did we do? First, I said at the beginning, my goal was that 20% of people who we started, we would still be seeing or treating in some way after 3 months. It's very I'll admit, it was a very modest goal, but this was a population of people who were not seeking treatment. We went to them. They were a population of people who were homeless, very chaotic, often also using methamphetamine. Basically, your least likely to succeed population. We far exceeded that 20%. We had 51% who stayed in treatment at 3 months. That was great. By the end of a year, of the people who started in the beginning, still we were at about 20% who we were still seeing. Actually, once we run this out to 2 years, quite a number of the people who we started came back to us. So we're still running in the range, if we look at 24-month retention and care, it's still running in the range of 25%. It's pretty amazing to me. So we considered that a success. Most of those people actually kept taking buprenorphine. Some of them changed to methadone. Some of them stopped buprenorphine. Maybe they went into a treatment program. Maybe they were not ready to change the way they were using drugs, but they were still coming to us. So that was a real plus. 70% of people came back to us after the first time. Now, when we talk about drug treatment, maybe the model that is the classic model and what we might look for is you start treatment and you stay on treatment, and you either stay on treatment indefinitely or you finish treatment and you're all done with it. We know that addictions are not an all done with it kind of illness. So right there is a problem if we think that there's any treatments that we should be all done with it. But what we found in doing this work is lots of people started, stopped, started, stopped. They might go a few weeks, stop for a week, do it a few more weeks. They might go for a few months, stop. All different patterns, and we're going to look at all those patterns. But again, very importantly, during those times when people were on treatment, if you're on buprenorphine, one of the characteristics of buprenorphine is that you're much less susceptible to an opioid overdose. It blocks the effect of opioids. It's great. So is it a problem? People are on it and off it? I look at it as saying, if you're on it, that's one day that you're not using needles, putting yourself at risk of hepatitis C or HIV or another infection. It's one day that you have less risk of an overdose. And we need to look at that, but one of the things we found was very few overdoses in the course of time. And most of our patients used our public health pharmacy. Most of our patients were taking their buprenorphine, and most of our patients continued to use opioids at some degree or another. And many of our patients continued to use methamphetamine, which is probably not surprising because buprenorphine doesn't help methamphetamine use disorder. Now, it'll be interesting to see over a longer time how that changes. But 36% of our urine toxicology tests were opioid negative. So at least some proportion of the time, people were not using. And that is really important, thinking about a group of people who really, when we met them, were not seeking treatment. Again, another way of looking at it, another third of the people, at least once, they had an opioid negative test. That's great. And a small proportion, but a real proportion, started buprenorphine, stopped using opioids altogether. And that's pretty cool. So adverse effects, we had 2 deaths. Both deaths were in a very typical pattern for overdose deaths. Somebody gets put in a jail, and somebody gets released from jail. Their tolerance to opiates is less. The only thing they can think about when they get out of jail is, I think that I don't want to go back to using drugs, but just this once. And then they take their usual dose of drugs and die. In San Francisco, we do a pretty good job of getting people on buprenorphine who need it at the time they're leaving jail. I believe that both of these cases were people who were in jails outside of San Francisco County. And even the jails outside of San Francisco County are getting with it now and realizing it's really dangerous to discharge somebody with a history of opioid use disorder without some kind of protection, the best being starting buprenorphine and having a plan for how it's going to continue. There were several overdoses that were reported to us as requiring naloxone. They were thought to be related to heroin or fentanyl use. And then there were other people who said they had an overdose, but they didn't need naloxone. What are the challenges? The demand outweighs the capacity of our team. We have a small team, although we're growing. I'm glad to say that San Francisco city fathers and mothers heard these results and said, we want to support this in San Francisco, and actually specifically supported an expansion of this in the budget last year. It's really hard once we start to find another place for people to continue their treatment. People are still pretty unstable, and they're sticking with us. We know that treating methamphetamine and opioid use is very difficult. We also know that methadone and opioid use is a big driver of our homeless deaths. So we've got to really work on what do we do with that combination. And ultimately, this is really hard work. This is where I stop and say, this much homeless people, this much housing. This much homeless people, this much housing. One of our patients can do everything right. They can come to every visit with us. They can use the buprenorphine. They can get off of opioids. They can get off of other drugs. They do all that right. At the end of the year, the high likelihood is they will still remain homeless in San Francisco. And homelessness is a huge driver of bad health. So it's a challenge, because we'd like to say, hey, if you do this all right, then the reward is your life will get more stable. And of course, when your life gets more stable, you should be able to afford and keep housing. And it is not so in our current economy and our current state of homelessness and housing in San Francisco. And of course, it's not just here. Strengths, the team was already working with the population. I've been working with buprenorphine since it was approved, and have extensive experience with prescribing. We had the opportunity to work with a pharmacy, the Department of Public Health, Community Behavioral Health Pharmacy, that really wanted to work in an intensive clinical way with this population. And the Department of Public Health has a real commitment to harm reduction. I'm not going to go through all that writing, because I already said all that. Here's an update. As of when I made this slide 2 days ago, we had 490 patients who were prescribed buprenorphine at least once. 150 of those patients were active, meaning that we have seen them within the past 3 months. More than a third are retained in care after 1 year. And we have a lot of different kinds of success stories. We have people who have that classic success story. I came to you, I was on drugs, I was going back and forth to jail, I was going to prison. I felt like if I kept on that road, I'd be dead in a year. You can read about this case in the newspaper, because our patient has been very generous with talking about his story. I met Dr. Zevin in the alley. He prescribed buprenorphine. I started taking it. It was a little bit on and off at first, but then I really started taking it regular. I stopped using all drugs. I met someone. I was able to go back to school. I was able to get a steady, permanent relationship. Between the two of us, we're able to afford housing. I've got a job now. You saved my life. It's the classic story. I'm not going to say it doesn't happen, but that's not our typical success story. Our typical success story looks more like, I didn't have a doctor. I hadn't seen a doctor maybe since childhood. I was using drugs. Somebody came and talked to me about, did I want to change that? I wasn't sure, but I was feeling bad that day or the next day. I said, yeah, maybe I'll try this buprenorphine. Maybe I've tried it on the street before. Maybe I tried it somewhere before, and I know it works, or my buddy told me it works. I tried it. It was great. But then I didn't go back because I felt so great I didn't think I needed anything. So then I went back to drugs. Then I was back doing drugs, and I was kind of ashamed to go back to that doctor. But then finally, I saw that it was the same doctor working in the navigation center I was at, so I went back to that doctor. So I started again. Then I kept on it for a couple months, and it was pretty good. Then I got really spun on methamphetamine, and I had to go to psychiatric emergency. But after I got out of there, I went back to the doctor, and I got back on the buprenorphine. And I'm still homeless, and I'm still kind of using methamphetamine, but I'm coming to the doctor more, and I'm getting ready to have my hepatitis C treated. And the same doctor is willing to treat my hepatitis C. And, you know, I never thought I would, but I'm talking to doctors and nurses like 2 or 3 times a week, and I feel like they're kind of part of my family and my support system, and maybe I've got a little more hope than I had a year ago. That's more like the kind of success story that we have. So what else do we have in the practical harm reduction world? Well, I mentioned buprenorphine, which I will say, I don't necessarily say to my patients, this is the miracle drug, but a lot of them say that to me. Even when they haven't really stopped using drugs entirely, the idea that they can reliably have something that they're not going to wake up and have to spend all day doing things to be able to obtain drugs, wake up the next morning, do it again, the next morning do it again, that's a miracle for them, that it works and will do that. And people report that. And I will say, that's great. And the more of this we can get in the community, because it's a safe medication. 0% of the toxicology reports for our homeless deaths had buprenorphine in it. That's encouraging. So more buprenorphine, good harm reduction. More overdose prevention, good harm reduction. More attention to what are we going to do about methamphetamine users and methamphetamine use disorder, and innovations in that area. And then some practical ideas. People probably have heard of safer injection facilities. This is an idea that is really picking up steam. Numerous sites in Canada, numerous sites in Europe, 0 sites in the United States. What is it? At its most simple level, someplace where people can go that's not the street or a back room or an alley and use drugs. We're not giving people drugs at them. They're bringing their drugs. We're giving them clean equipment. We're supervising them so that if there is an overdose, it can be rapidly identified and reversed. And we're talking to people, giving people hope, treating people like human beings. And that has an amazing effect of people who every day wake up and say, I can't go on like this. My life can't possibly go on like this. And yet, every day their life goes on like that. Come into a facility like this, they're talking to people, and at that moment where they say, my life can't go on like this, there's somebody there to say, hey, here's some options for you. Obviously, we can use buprenorphine and start buprenorphine at a site like this, or get people into various other kinds of treatment. So, will we have a safer injection facility in San Francisco? The politics of it are brutal. Federal government is implacably against this. How the federal government can say we want to address the opioid crisis and say we are absolutely opposed to this very good evidence intervention, I'm not sure. But that's the politics of addiction, which are mostly thought of in terms of a moral model. So that is that's my last slide. I want to thank my colleagues and my patients who I learn from every day, the Street Medicine and Shelter Health Team, our SFDPH UCSF Addiction Medicine Fellowship, and Jamie especially, the San Francisco Whole Person Care Initiative, including the UCSF evaluation of whole person care, and SFDPH, Amber Reed from Whole Person Care, who helped a lot with the design of these slides. My email is here, and the website for Whole Person Care is here. And I thank you for your attention, and I'm happy to answer questions. I'm happy to repeat the question. California appears and does have a disproportionate number of the people experiencing homelessness across the nation. And why might that be? And obviously the honest answer to that is, I don't know. But when did that ever stop me? So I will speculate a little bit based on talking to people all over the country. First of all over the country, every city in the country, people believe, everywhere in the country, the cities are sending us their homeless people. New York, Philadelphia, Birmingham, Alabama, Cleveland, Denver. I talk to people all over the country. First thing people say is, people are coming from all over the country. They're being sent to our city. Well, they're not being sent to your city. People who are homeless and poor people in general are looking for an opportunity somewhere or other, and if it's not here, it's somewhere else. And possibly California does have a disproportionate amount of people whose last hope is, well, I'm going to go to San Francisco, I'm going to go to Los Angeles, there's got to be something for me there. And there's probably some truth to that. It may have something to do with the way that counting is done on the single night count. That single night count methodology for counting people experiencing homelessness is, you're an epidemiologist. I don't think that's what you would have come up with as the methodology for what's the ultimate way to know how many homeless people there are in the United States. At least it'd only be one of several methodologies. Going back to the original principles, do we have more poverty here in California? We might have more disparity of wealth in California than some other states. We certainly seem to be losing our working class and our middle class, especially in cities like San Francisco, at a pretty fast rate. Do we have less affordable housing here? And the answer to that is almost certainly yes. The housing stock, if you look at what housing has been built and what income level is it built for, I definitely, from my understanding of it, we lag in building affordable housing here, or just having it. I mean, someplace like Salt Lake City, which famously was advertised as Salt Lake City, the city that solved its homeless problem. What did they do? Salt Lake City has dozens of square miles of land that's suitable for housing of some kind. Salt Lake City took some of that land and said, we're building the cheapest imaginable housing in it, little communities, small places that might be shared with 2 or 3 bedrooms and a bathroom in a little complex, and built 500 or 1,000 units of that. The land cost next to nothing because they have a lot of it. The building of it was also relatively inexpensive because they were building a lot of very similar kind of adequate but limited units. Someplace like San Francisco, where would you build it? You'd have to make a commitment to building low-cost housing someplace where owners of that land are feeling like, I'm sitting on a gold mine. Even if all I've got is a warehouse on this gold mine right now, I know what land costs in San Francisco. And we don't have a place to put people. We've had a great expansion of housing in San Francisco. We see all the high-rises going up over the past few years. Even rich people can't afford to live in San Francisco. And we have built a number of units for people who are poor and for people who are extremely poor and experiencing homelessness. But no way does that come close to the 14,000 or 15,000 people who need that. I don't know if that answers it. It's speculation, but it's a thought. Other questions? So the question is the number of people who we treat who are able to transition out of homelessness. And I'll make the distinction between, as I started with, do people get a home, or do people get a temporary shelter, or perhaps a barely adequate room in a single room occupancy hotel. So I don't have a slide on that. I don't have an exact number. Quite a number of our patients are able to stabilize in a shelter or a navigation center. The problem with that model is we have somewhere around 1,200 shelter beds and navigation center beds, and somewhere around, at a minimum, 3,000 or 4,000 people who are street homeless. You think about that, the solution that historically has been proposed for that is, well, we'll shuffle people in and out. The maximum stay in a homeless shelter is 90 days. The maximum stay in a navigation center is usually 7 days or 30 days, or if you've got a pathway to housing, something where you are one of the select few who's been prioritized for housing, then you can stay there indefinitely. So if you think about it, somebody who's out there and they're very chaotic, we can start them on buprenorphine. They get less chaotic, and then they're able to stay at the navigation center. It's like, great, finally I've got into this navigation center, 30 days, just beginning to stabilize. My brain is just beginning to recover from all of the chaos and violence and loss and trauma of being on the street. Sorry, your 30 days is up. There's really no housing for you. We could offer you a ticket home to go back to your family. Home, what's that? Family, the family is why I'm out here in the first place. Okay, I'm going back to the street. Some other person who was on the street might go into that slot, but we don't have a good model for, hey, you stabilized enough so that you can go from street to this other thing. How do we keep you in this other thing until you can get to the next thing? I talk about that a lot to my colleagues in the Department of Homelessness and Supportive Housing, because I think that is a very problematic model that we have. Understandable from an equity point of view, possibly. We want to give everybody a chance to have this thing. I don't think that people realize just how unappealing it is if you're living semi-stable, even if it's in a doorway or a tent under a highway, to say, I'm giving all that up, I'm going in someplace, but at the end of that moment, I'm going to be back out, and I'm not even going to have my doorway or my tent under the highway. So that's problematic when it comes to how many people and how can we stabilize them. So the question is, when we assess people, before we give them buprenorphine, do we determine that they have an addiction? And if they didn't have an addiction, what would happen if you took buprenorphine? So that's a great question, actually. You introduced yourself as somebody who had little knowledge of street drugs, but actually I find that to be a very sophisticated question, so thank you. Yes, the best practices for use of buprenorphine are to only give it to people who have a history of moderate to severe opioid use disorder. And in the past, that's actually been a barrier to treating some patients. Somebody would go to the doctor, say, I've got an addiction. The doctor would say, more or less, prove it. Well, that may be easy or not. For most of our patients, clearly to have an addiction and to be on the street is pretty sure that they're getting into the severe substance use disorder category. How do we know if somebody's got an addiction? We look at medical records. Has that person been in treatment before? Did they have tests or history or emergency room visits that show that they didn't just pop out of the woodwork, that they already have an addiction? So we look at medical records. And I can do that even in a street-based setting usually. We look at physical signs. If somebody's using a needle, they often have needle marks or track marks or other signs that they have a drug use pattern. We take an extended history. Most of the time, I'm an experienced provider. Most of the time, it's clear to me if somebody is saying, I have this, I'm going to be probing into, well, tell me about it. Tell me your history of drug use from when you started to where you're at now. Most of the time, it's very clear. This person clearly has a substance use disorder. And remembering that it's a lot of trouble to go through if you don't, to try and get buprenorphine, which we're trying to make very available, which actually I'm hearing from patients, yeah, the street value of buprenorphine is way down. Because in other parts of the country, the buprenorphine does have a street value. Now we know if you ask people who are buying it on the street, why'd you buy it on the street? It's almost always for the same reasons that we prescribe it as a doctor. It's not something that very reliably gets somebody high. It's something that very reliably takes away craving and withdrawal. All that said, every so often, it happens that I find somebody who maybe they have another kind of addiction. They have a methamphetamine use disorder or a cocaine use disorder. And they've heard buprenorphine's really great. And they've heard the way to get it is to say that you're addicted to heroin. They come in and say, I'm addicted to heroin. Take the history. It's clear that that's not really the case. But I suppose it could happen that somebody isn't. How serious would it be to make a mistake? And that's sort of the good news about buprenorphine. Because even somebody who has no tolerance to opioids, at the doses that we're giving, it's very forgiving in terms of a fatal overdose. It might make somebody feel sleepy. It might make somebody vomit. Often somebody who's never used an opioid, the first time they take buprenorphine, will actually have nausea and vomiting. That could be a sign. They might come back and tell me that. But they're unlikely to have their breathing slow down so much that they have an overdose. So pretty safe, even in that category. In the world of prescribing this in general, we counsel people. Do you have children around? Do you have kids in the home? Well, we're talking about people who are not homeless. Because I do worry about the possibility that there could be an overdose if a child got their hands on this and started to suck on it. But it's unusual to have children, young children, around our population. And we still really try and pay attention to avoiding those kind of risks. So I think, did I answer that question? Great. Okay, a couple of things. The first question was, what's the difference between buprenorphine and Suboxone? So another excellent question. Suboxone is a brand name. Buprenorphine does come in two forms. Buprenorphine as a single, alone product, and buprenorphine combined with naloxone, which I already said is the short-acting antidote for an overdose. Well, why would you put that in there? Well, when they approved this drug, the DEA was very concerned that, well, buprenorphine, maybe people will want to inject it to get high. After all, people try and get high on anything. And if we put it with naloxone, it would block the effect if people injected it. It turns out that naloxone isn't absorbed in the body sublingually, the way that we prescribe all buprenorphine, or swallowing it. I spend hours, the amount of time I've lost in my life having to explain to people that the naloxone that's in Suboxone and other buprenorphine naloxone combinations is only there because the DEA wanted it to be there. It has no medical effect, and it has no clinical effect, and it's doing nothing but driving me crazy in trying to counsel and educate patients. So that's why the naloxone is there. It's doubtful that it's even achieved the original intention of the DEA. It's interesting because in most of the United States, there is very little diversion. And the diversion there is, as I said, is for the same kind of clinical uses. But there's a few places in the country, Burlington, Vermont, Rochester, New York, maybe a couple other places where they actually have a problem with people injecting buprenorphine. Why there? I don't know. But my approach would be different if I was working in that kind of place. The second question, if I can remember it, was, give me like one word. Oh, accessing naloxone if you want to be somebody who could administer it if you were as a citizen. It turns out that that we can ask a pharmacist anywhere for naloxone. You should be able to go to your local pharmacy and get it. Some pharmacies are very good with this, others are not. If you happen to have a pharmacy that won't do it, you can pick up naloxone as a citizen of San Francisco at the CBHS pharmacy at 1380 Howard Street. Just walk in. If they say, no, Dr. Zevin told me I could.
Not a San Francisco resident,
They probably won't ask you for an ID.
Okay.
But similar in Oakland. But I'd recommend you go to your regular pharmacy.
Sure, because I've been, they've been giving me trouble for it, so I wasn't sure if it was actually, you had to go through a special
You're really not supposed to, the way the law is written now. It's also possible, if you want your insurance to cover it, to go to your doctor and have your doctor write a prescription for it, and it should be filled. So, well, why do you need that? It's like, because I live in San Francisco, or I walk in San Francisco, or I walk in Oakland, and I don't want to walk by somebody who I could have saved their life. And I'm encouraging people to do that. So that's how you get naloxone. If you're really brave, or I shouldn't say it that way, if you're curious, you can go to a syringe access or needle exchange site in San Francisco or Oakland and just ask for naloxone. They'll train you how to use it. We're wrapping up. Thank you, everybody, for coming. Thanks, everyone.